Bismillah ar-Rahman ar-Rahim, my dear vascular colleague. This lecture is how to study guidelines of vascular surgery. It is a very important topic, and I think it's very important to create a system for you how to study vascular guidelines because they are important for cases, they are important for you in the exam, is extremely important, and they are very important in clinical practice too. So I collected here my advice. Number one, start with Bismillah ar-Rahman ar-Rahim. And this is, I can't say how extremely important it is. Secondly, I prefer to have a digital format. So you can see I am using a program called OneNote. I think it's one of the best note-taking program. And I was able to make a notebook that have all the vascular guidelines. So I think it's better to use a pen. There is a lot of study to show that memory, when you are using a pen, is so much better without using a pen. So you can use digital pen. If I want to show you here, this is the guideline I have created. For example, here is the arterial guidelines. All the arterial guidelines found on this column. Now, venous guidelines, all of them are in this column. Aortic guidelines, and so on. And each of these vascular access guidelines, irradiation safety, pulmonary emboli, carotid, mesenteric, diabetic foot, pregnancy, also vascular surgery guidelines. So I usually put them in a sequence of date. So the more recent will be above, and as you go, it will be much older. So you can see here, this is aortic guideline 2024. And this is guideline 2022, 2021, 2020, all of them aortic guidelines between American and European, 2019. And as you go along, it will continue to go backward. This is very important for you to know exactly how recent is your guidelines. So I've created this digital copy of vascular guideline, which contain all the guidelines that you can see, all of them. And you can just have a QR code, and this QR code, you don't need to download anything else, only the QR code. But the QR code will open a data which is like 1 gigabyte. So it's very important to give it time to open, and don't do it from your mobile. Better to have your laptop and the DSL. The beauty of having digital format is you can do highlight, as I will show you. Important point, you put it in yellow. You can put a star on what is very important for you to memorize. And the vital information, you can put it in pink. This is usually my code. And you can use artificial intelligence to create summary. This is one of the recent tools in the guidelines that will summarize your guideline. Here is one notebook which contain all vascular guidelines, so you don't need to search over the web or anything like that. So this is the QR code. If you stop the video at this stage and put your mobile app into this QR code, you will be downloading all the guidelines available for vascular surgery. Not only this, but I like you to have a certificate of you while you are studying. So now there is a mid-all, which is a very, very nice website, which have a free medical information. I already have an account on mid-all, and I will already put all my vascular guidelines here. into vascular online training. You can have also duplex ultrasound skills. You can have the Egyptian Vascular Club activity, also MRCS activity. Now, when I put a lecture on mid-all, it will give you a certificate that you have watched the video, and it will give you a proof of your study. So I would recommend you to go to mid-all. I will upload this lecture and then you can download it from there. Now, Professor Assam Al-Adi have asked me to give a presentation on aortic thoracic guidelines. So if I open here, 2017 thoracic guidelines, and if I go up to the beginning of the guidelines, here is what I mentioned. It's about 43 pages. There are 80 recommendations. I would advise you to have 3 hours of a study, because one of the big mistakes that vascular surgeon and vascular fellow face, that their studying time drops. Used to have 3 hours, then it becomes 2, then it becomes 1, and then when you go to exam like MRCS exam, it is 3 hours. So you can have something like 18 stations, and some of the fellow, because they are not accustomed to 3 hours continuous mental work, they usually in the last hour they are exhausted, they are not used, they are mentally blocked. So please, when you study vascular guideline, prepare yourself for 3 hours straight constant studying time. Now, Professor Assam Al-Adi have asked me to speak about management of descending thoracic aneurysm. This, as you can see, is 2017, and all this are more recent to that, because in that era, thoracic aorta was different from the abdominal aorta. So it was thoracic aorta, abdominal aorta, and there was also ascending aorta. So there were different places. Now, what we all agree is aorta is one organ. So the aorta is just one organ and should be treated as such, starting from the aortic valve down to the bifurcation, divided into different zones. But in that era, which is 2017, it was thoracic descending aorta started to become one of the interest area for vascular surgery. This, you must know basic fact. Number one, the year is 2017. Secondly, it was by the European Society of Vascular Surgery. This is very important for you to know. The European, and probably you need to have a look at some of the people in the writing committee, which is Stéphane Moulin from France, Michael Jacobs from Netherlands, Eric Verhoeven, again, one of the very big name for descending aorta. So, as we said, we have 43 pages and we have 80 guidelines. This is the document. I usually have summary of the ESVS. I put it in slides like this. These are the slides that will contain all the vascular guidelines. And I can divide them into diagnostic or therapeutic. And these are all of the 80 guidelines. You can see here are the guidelines, the strength of evidence, and the number of the guideline, what number it was. Also, I have another copy, which is a clean copy. This copy without marking at all. But I prefer for you to mark And before you study guidelines, ask questions. When should I treat thoracic aortic aneurysm? What are the best methods to treat thoracic aortic aneurysm? What is the anatomy of the thoracic aorta? How to deal with trauma, for example. All this, put them as a question for you before you start, because this will prepare you for the next section where you are going to answer these questions with an evidence. So this is a beautiful document. Here you will get the content, what is normal, this is important, and then we're going to discuss spinal cord ischemia, which is important for paralysis as a complication, paraplegia as a complication. What is acute aortic syndrome is also very important. And you can see ruptured aneurysm, blunt trauma. All these are very important topics with very important guidelines. And here are the things that need to have more evidence, so they couldn't get a guideline. And this can be quite a good topic for MD and for research. So we'll go down. This always give you the abbreviation of, for example, Lloyd's-Dietz syndrome, LDS, left heart bypass, LSA, left subclavian artery. So these are the abbreviation that are going to be used, and I recommend you to read them quickly, because whenever you get abbreviation, you want to know what does it mean. For example, WC is writing committee, who have did write this guidelines. Now we're going to shuffle through quickly into descending thoracic aortic aneurysm, hoping to get the maximum benefit to everyone. So let us start. This is page number 7. Here is very important, the level of evidence. The level of evidence, either A or B or C. C is general consensus, and A is the strongest evidence that we can have. This is very important, and I did put a star on top of it. Second information which is important is the class of recommendation. And notice that this will go in all our guidelines. This is the American standardization of classes of guidelines. We have class 1 that should be performed, and class 3 is not recommended. Between two, class 2 is divided into 2A and 2B. And very important here to see the wording. 2A should be considered, and 2B may be considered. So, for example, you need to stick to class A and class 1 and the class 2A. Some of us go to up to 2B in some circumstances, but obviously don't go to class 3. This is important. This is important question. What is the normal diameter of descending thoracic aorta? And here you can see it's a topic, and here I did put, because this is very important for the exam and very important for clinical. The normal diameter of the mid-descending aorta between 24 to 29 millimeter in men and 24 to 26 millimeter in women. Whereas the normal diameter at the level of the diaphragm is 24 to 27 in men and 23 to 24 millimeter in women. This is what is normal aortic diameter, and this is extremely important information. It's also important to know the anatomy. The aortic wall is divided into 3 layers: intima, media, and adventitia. And that is why I usually put in the guidelines image to help me to remember. So this is a very important image. from the European Society of Cardiology. You can see this is a blood, this is intima, media, adventitious, the three layers, and the areas are divided into smooth muscle layer, the elastic lamina, the vasa vasorum, the internal elastic membrane. Some of the examination European board will tell you, please draw a cut section of the aorta, and that is why this is very important image to remember. Here is another image after the one for the anatomy, which is extremely important for understanding of all the pathology. This is aortic dissection, and you can see a small area with intimal crack. And this is intramural hematoma, which is a closed space. And the third one is the penetrating ulcer, which is hematoma and ulcer. This is a very good drawing, again, from European Society of Cardiology. And here is a cut section. So you can see this is the intimal tear in case of dissection. This is a closed space, intramural hematoma, and this is the penetrating ulcer. So it's very important when you are reviewing an image on CT or MRI to have this crucial nomenclature of these pathologies. So all this three pathology is called acute aortic syndrome. So there is acute aortic syndrome, there is acute coronary syndrome, there is acute carotid syndrome. This is the acute aortic syndrome, or AAS, consists of three interrelated diseases: aortic dissection, penetrating ulcer, and intramural hematoma. Why they mention that it is interrelated? Because sometimes dissection can be converted into a hematoma, and then it can go back to dissection flap that you can see again. Again, aortic ulcer can go into hematoma if the ulcer has healed. So they are interrelated, and this is very important. And here is the incidence of acute aortic syndrome between 2 to 4 per 100,000. This is also important for you to remember. After that, we're going to discuss diagnostic method. And this is very important because we rely on CT scan. CT scan now is the golden standard for diagnosis of all of the descending thoracic disease. When he's going to discuss the diagnostic method, he's going to discuss plain X-ray. Plain X-ray as one of the first investigation. Why this is important? Because there is a big registry of acute aortic dissection called IRAD, International Registry of Acute Aortic Dissection, and the IRAD showed that in 21% of type B dissection presented with a normal X-ray. So the chest X-ray is normal. And this is very important because sometimes we bring in the exam a case of aortic dissection and we give you a chest X-ray which is normal. So this is an important information for you to know. So at this point, we start by our first recommendation. We know that we have 80 recommendation. And this is the first one, which is all patients with clinical suspicion of thoracic aortic disease with abnormal chest X-ray should undergo computerized tomography angiogram for diagnostic confirmation. So this is grade 1, level of evidence C, and this is the recommendation number 1. Here the collect related recommendation, you will see this in this guidelines. So 2, 3, and 4, all of them related to diagnostic, and they are important. It mentioned here that the CT angiogram
is the first line of diagnostic modality for diagnostic aortic pathology. And you must include from the origin of aortic cusp until the level of the femoral arteries in order to know exactly where does this section start and where does it end. It's also important that transesophageal echo can be used as a second line. So it says as a second line if you have the facility of it, it sometimes is useful. And the contrast-induced nephropathy, patient who's going to have contrast, borderline kidney function, you should give them sodium chloride, sodium bicarbonate solution, and isotonic sodium chloride before the contrast administration. Notice that level of evidence C, and this is 2A. I usually still do it because you want to save the kidney. There is a mention of PET scan and ultrasound, but they are nothing specific regarding their guideline. But this table is very important. This table, it mentioned here that in this table, you put transesophageal echo and CT angiogram, MRI, PET scan, IVUS, and you put here the characteristics. And this is very important. Is it easy to use? Is it available? Portable or not? Wall contour, supra-aortic vessel. So this is very important table that will give you information about the diagnostic modality. It's very, very important. That's why I put a star on it, and you will find it in this guideline. Recommendation number 5, it mentioned that evoked potential sensory motor, evoked potential can predict a spinal cord ischemia preoperative, but again, level of evidence is C. So they consider this as 2B. Most of the interventionists doesn't use evoked potential, but main thing is to keep the blood pressure up and to be sure where the perfusion of the spinal cord and the CSF, and all this will come in later guidelines. Now, this is regarding spinal cord ischemia, and this is the recommendation between 6 to 9. You can see the level of evidence is not very high. Some of it are C and B, but they are very important. It mentioned that you need to CSF need to have monitored, and this is essential. Most of us who do thoracic surgery must have CSF monitored by the anesthetist, and to prevent spinal cord ischemia, left heart bypass allow distal perfusion during open type of repair. In extensive type repair, also hypothermia to 32 can prevent spinal cord ischemia, and this is duty of the anesthetist. And combination of hypothermia, CSF fluid drainage is not recommended during open descending thoracic aorta, as it can increase subdural hematoma. So this is very important, is the level when you are doing too much. If you're doing cooling with CSF drainage, is not recommended in open descending aorta because it will cause subdural hematoma. So class of evidence is 3, and the level of evidence is B. Now here is important recommendation number 11. In elective thoracic endografting, T-bar cases, where it is planned to cover the left subclavian artery, in a patient at risk of neurological complication, prevent the left subclavian artery revascularization should be considered. And here, should be considered. You can get away without complication, but it should be considered. And some papers say it is safer to do either carotid and carotid subclavian bypass in order to perfuse the left subclavian artery. So this is very important recommendation. Now this is very important diagram. You must Memorize it very well before the exam, because this is the Bakey classification 1 with 2, 3A and 3B, and Stanford A and B. And I will show you a slide where all this is explained. Here is a diagram. As you can see, Stanford A and B. Stanford, if you start from the ascending aorta all the way down, or only ascending aorta, this is Stanford A. Stanford B, which is start below the subclavian artery, so the arch is normal. And this is Stanford classification. For the Bakey, this is the Bakey 1, and this is the Bakey 2, which is ascending aorta, and this, both of them should be cardiothoracic surgeon. Now the Bakey 3, either 3A or 3B, and this can be done by peripheral vascular surgeon. So this is very important scheme of the classification of thoracic aortic dissection. The recommendation 13, 14, 15 are very important. They are speaking about medical treatment. So medical therapy should always be part of treatment of patient with acute type B dissection. And in patient with acute type B dissection, beta blocker should be considered as first line of medical therapy. And again, if you don't have a response with beta blocker, calcium channel antagonist, and renin-angiotensin inhibitor system considered as alternative. And we usually refer for control of blood pressure for the internal medicine. Now, in 2017, there was the beginning of doing the procedure which is called TVAR. And this procedure is very important because in the past it used to be referral to cardiothoracic surgeon. So in patient with complicated type B aortic dissection, TVAR should be the first choice. And this is important recommendation. In complicated acute type B, again, endovascular filtration should be considered to treat the malperfusion syndrome. So this is very important, three recommendation from this guideline. I wouldn't go through all the recommendation, but I will make a hint about important ones. This one is important, recommendation 23 and 24. In patient with ruptured descending aortic aneurysm, endovascular repair should be the first treatment option when the anatomy is appropriate. And in emergency, ruptured descending thoracic aortic aneurysm, patient with left mammary to coronary bypass, LEMA, with a dominant single left vertebral artery. This is extremely important, very, very important, and usually bring it cases in MRCS vascular. They get you patient with LEMA, with a dominant single left vertebral artery. Left subclavian artery revascularization should be performed prior covering left subclavian artery, because if you don't do that, you will get a stroke in the brainstem, and this is catastrophic. In the next part of the guideline, we're going to speak about aneurysmal formation, thoracic aortic aneurysm formation, and these are the recommendation between 40 to 44, and they are speaking about what to do for thoracic aortic aneurysm. For example, computerized CT angiogram should be performed in patient planning descending thoracic aortic repair to define the extent. Obviously, this is a very obvious recommendation. Candidate with open surgical repair descending thoracic aorta aneurysm with past medical history of chronic disease, additional diagnostic investigation should be considered. Obviously, you must do a full checkout, both neurological, coronary, and the carotid before you go into, because these are the common postoperative complication, and all this should be done. And the endovascular approach is dominant rather than the open approach, and you must discuss multiple elements of the anatomy. By this, I would have reached into the page, which is page 27. And by this, we nearly at half of the descending thoracic guidelines. I will discuss the other half in the next presentation. So hopefully with these two lectures, you will have a glimpse of the guidelines. You will start studying them. With the QR code, you can download all the guidelines, and then it will be easier for you to remember them before the exam. And thank you very much. And this is the first part.